هذه هي كيو اند اي.
ايوه بالضبط هذه تصير.
ايش نسوي فيها هذه الحين؟
احنا حنبدا نسال.
طيب
شكرا.
هو كذلك.
توفيق ان شاء الله.
انا بس بحط بعض الصور اللي البوسترات بس ما اقدر اصور.
ايوه تمام. كيف دكتورة حنان؟
الحمد لله. كيف حالك بروف؟ كيف صحتك؟
ايوه كيف حالك دكتور؟ الله يسلمك يا رب.
الله
يخليك.
الله يوفقكم ان شاء الله.
امين يا رب.
امين ان شاء الله.
وين راح الكويشنز والاشياء هذه؟ دكتور علي يبدا.
السلام عليكم.
وعليكم السلام. حياك الله.
السلام ورحمة الله.
كيف الحال؟
شيبنا اهلا شيبنا.
كيف الحال؟ ايش اخبارك؟
اهلا مرحبا. بروف اسامه كيفك؟
الحمد لله. كيفك انت؟ كيف صحتك؟
على كيف الرطوبه عندك هناك؟ الله يعيننا وياكم يا اخي.
الرطوبه والحبسه.
سعداء بشوفك والله يا بروف. الله يحفظك.
الله يسلمك. كيف صحتك انت؟ كيف امورك؟
والله الحمد لله بنعم. الله يحفظك. سلم.
كيف الريزيدنت حقتنا مسويه عندكم؟
ما بريزيدنت. She's a consultant.
fellow.
الآن consultant. She is working as a consultant. You will be proud of her يا برو إن شاء الله.
أنا براود من غير ما أصير consultant. أنا واز براود وفير وأنا كانت ريزيدنت.
الحمد لله. لا
الحمد لله. يبيض الوجه. الحمد لله. الله يسعدهم.
الله يحفظهم إن شاء الله.
يا رب إن شاء الله.
كيف الريزيدنت حقتنا؟
عبد الرحمن. عبد الرحمن, you can start now.
Assalamu alaikum. Good evening, everyone. Today we're going to start our fourth Saudi Ophthalmological Society webinar session, which will be under the Saudi Glaucoma Group with the title of Glaucoma Fellows Round with Experts Case-Based Discussion. I'm Abdulhan Darrab, the moderator of this session. Our panelists today, Prof. Saleh Al-Baidan, he's a professor of ophthalmology at King Saud University and glaucoma senior consultant at Eye Consultants Center in Riyadh, Saudi Arabia. And Professor Osama Badib is a professor of ophthalmology at King Abdulaziz University and a senior glaucoma consultant at Basafar Eye Center in Jeddah, Saudi Arabia. Our sponsoring company is Mundi Pharma, and its representative is Mr. Shadi. Thanks to them for the sponsor. We're going to start our presentation with Dr. Hanan Jamjoom. Dr. Hanan is a glaucoma fellow at King Saud University in Riyadh, Saudi Arabia. Dr. Hanan, you can start.
Assalamu alaikum. I'd like to thank everyone for giving us this great opportunity. And I can start sharing my screen. I think the host should enable me to share. Dr. Abdulrahman.
Dr. Shamrani, can you give her the availability to share her screen, please?
I'll do it now, just a minute. Huh? You can go ahead now.
Can you see my screen?
Sure, yeah.
Yes.
So I'm going to present this case. He's a 75-year-old diabetic man where he was referred to us from the retina clinic complaining of decreased vision in the right eye more than the left eye. He received multiple anti-VEGF injections in the retina clinic and PRP for both eyes. For right eye, severe NPDR and left eye CRVO. Before that, he was following elsewhere, where he was diagnosed as pseudo-exfoliative glaucoma and given alpha-GAN, Cosopt, and Zalatan for both eyes. And he underwent cataract surgery for the left eye, where he developed vitreous hemorrhage after that and underwent vitrectomy. So the first glaucoma visit, his vision was counting fingers in the right eye, around 5 feet away, and hand motion in the left eye. Intraocular pressure was 17 and 14 millimeters of mercury with applanation tonometry. Slit lamp examination of the right eye showed clear cornea, deep and quiet AC, with 3+ nuclear sclerosis, and he had exfoliative material apparent on the anterior lens capsule and the pupil border with no NVIs in the iris. His left eye was quiet pseudophakic with no NVIs. Gonioscopy of the right eye showed open angle with narrow approach and pigmented trabecular meshwork as he has pseudoexfoliation. And the left eye was synically closed in 270 degrees. Fundus exam showed advanced cupping in both eyes, 0.9 with diffuse cup in the right eye and total cupping in the left eye. The rest of the retinal exam was stable NPDR with PRP marks in the right eye and ischemic retina with PRP in the left eye. His central corneal thickness was average in the left eye, but a bit thinner in the right eye. So we were adding plus one to his measured IOP. That was this photo is a bit hazy, but that's the best I could find for the fundus, which was taken in back in 2018 in the first visit to the retina clinic, just to show you that he had large cupping in both eyes to start with. So now I'd like to stop at this slide to hear from the panelists their opinion in regards to approach this case. I'll put the examination for you again.
Okay, well, Osama, yeah, go ahead.
Bismillah wa salatu wa salam ala Sayyidina Muhammad. I would like to thank everybody for inviting me for this session. And this is one of the typical cases we are seeing every day in the clinic. For the last 35 years, I saw a lot of cases like this. One eye person, he is 75 years old. So most probably he doesn't have a lot of years to live. The other thing, he has a lot of problem in his eyes. He has almost total cupping. He has exfoliation, glaucoma. His cataract is not that bad. He should see better than counting finger. And if we compare the two picture of the two eyes, the one which is pseudophakic and this is with the cataract, we don't see much difference. So the cataract is not significant and is not the main cause of decrease of vision. I think the main cause of decrease of vision may be the glaucoma for a long time, diabetic retinopathy, and he has all the BRB and so on in the right eye. So those patients, when they come to see me, I tell them that you have one eye, and it's my advice against any treatment for those patients. Why? Because there is a big chance that if we do just cataract for him, he may have a lot of complication of cataract extraction and pseudoexfoliation. If we do for them trabeculectomy, they may wake up with the trabeculectomy, wiping his central vision, and he become blind. So the chance for him to gain more vision is not that much. And also the chance of complication is very high, and he is a one-eye person, and he doesn't have a lot of years to live. You know that average life in Saudi Arabia is between 70 and 80. So he have 5 years. Most probably he will live without counting figure until he die, or he may lose it. And I'm sure if we do something for him from the complication and so on, he may lose his vision and he become blind. So I will offer him nothing. I will tell him the pressure is okay. Your cataract is not that mature. Come, I will follow him. If his pressure become out of control and I cannot control it by medication, or his cataract become very significant and he doesn't see and he lost vision and his light perception or hand motion, then I will tell him that now we can do the surgery for him. And I saw a lot of patients like this. And when I was starting 35 years ago, I was doing surgery and so on, but I was shocked with the result. So I stopped doing that anymore. So I advise all the new generation, don't be heroic. Just leave those cases until they need the surgery, then you can do it for them if they lose vision from cataract or the pressure become out of control. Other than that, leave him to live the remaining of his life with counting finger, better than nothing. Thank you.
If you allow me, yes. Thank you, Prof. Osama. I agree with you totally in the left eye. The left eye. However, regarding the life span or so, it is with the God. Nobody can tell. He might live to reach 100 years or more even. Anyhow, so with this available data, of course, there is nothing about his refraction in the right eye mainly. Assuming that he's ametropic or mild refractive error, he's diabetic, his retina, of course, you say severe non-PDR, probably need to fix his retina if there is anything that can be done to his retina. Then from the photo that you have showed us, fundus photos, is definitely the cataract is, if the cornea is clear, definitely the cataract is affecting his vision and 3+ necrosclerosis. In addition to that, his pressure is 17, and you said that on a gonioscopy, he has another approach angle. Pigmentation is well accepted because he's pseudo-exfoliative patient. So I will go for cataract extraction in the right eye, phaco, without a glaucoma. He's, as Prof. Osama said, he's an old man and he's controlled. I think you said on 2 medication or 1 medication, something like this, Hanan?
3 medications, 4 actually, full.
4 medications. Still, I don't know about the status of his lids, his surface, his ocular surface. Probably I will go only for phaco, and most likely he will improve, his cataract will improve with removing of his lens, especially with narrow approach angle. And if I need to do, probably he needs further or to continue all his medication or some of them probably. So yes, I will pay attention to his retina regarding his diabetes. I will go for cataract in the right eye, phaco, emulsification alone, and to evaluate his pressure post-operative. And of course, left eye, I will do nothing. Yeah.
Thank you, doctors. Actually, as in the setting of the advanced exfoliative glaucoma with the NS3, where early cataract extraction is usually more recommended in exfoliation in comparison to other cataracts. Actually, we decided to go for combined phaco plus trabeculectomy with 0.2 milligrams per ml mitomycin C, which was applied for 2 minutes. And the surgery was uneventful without complications. Day 1, his vision was 2400. Intraocular pressure was 5 millimeters of mercury with formed diffuse bleb around 2+ with no leak. The cornea was clear with no leak from the phaco incisions. Moderate depth AC with patent PI and PCI oil in place. The retina was flat with no maculopathy or choroidal. So we treated him with routine post-operative medications of fluoxetine and prednisolone 4 times and gave him follow-up after a week. When he presented a week later, his vision was counting fingers. IOP was 4 millimeters mercury. He had a larger bleb than before. It was almost 4+. And just to note that his sponge is very thin. There was no leak from the bleb or the cornea. The AC was shallow with temporal iridocorneal touch with the tilted IOL, mainly caused by the shallowing of the AC, and it was captured by the iris with flat retina, no maculopathy or choroidals. So going back to history, he denied any trauma or eye rubbing, but his son reported some eye rubbing actually. So I'd like to stop again for your opinion. Prof. Osama?
I think the Prof. Saleh, he should approach this because he's the one who wants to do the surgery.
The age before beauty, Prof. Osama.
Okay.
I don't mind to start. No problem. So, yes, I have probably no major objections on the way he managed from the beginning to go with trap phaco rather than phaco alone. Yes, but in these cases, as you have seen, he developed either of you said there is no leak, nothing, and there is no choroidals even. So probably he developed with this old age with mitomycin C, he developed overfiltration. So I wish that either to put further sutures, I will not see any spontaneous movement of the aqueous under the flap on the table. I don't know what the situation at that time. And then deal with the pressure later on if the pressure is going to be high with massage or whatever. But I will go, I wish to see him next day with deep chamber with high IOP rather, I mean in the range of 20 or so, or even more than 20, rather than to see him in the below 10 or so. So yes, at this point, I would say that the management-wise, the plan-wise, it's okay, but unfortunately, he developed this hypotony, and you said that there was a iridocorneal touch. Most likely, with this pressure, most likely, he has some sort of peripheral choroidals. If you do UBM or so, you will find that anyhow. But as long, I'm sure you took a good care of him, and you did all needed things, whether I mean with the retina opinion regarding the peripheral choroidals or so. Anyhow, at this point, I will just go for atropine probably, and bed 40, I will stay the same and observe him. And this vision drop is most likely related to the, as you said, there is no maculopathy, hypotony-maculopathy. Probably this is due to with this high pressure, the sutures affecting his corneal smoothness and curvature. So I will wait. I will not rush for anything at this point.
Okay, looking at that, he has shallow on the temporal side of the AC, and also there is a tilt of the IOL. That could be from the ciliary body processes moving forward due maybe to peripheral choroidal detachment. That's why they didn't see it in the posterior ball, and that may be what caused this tilting in the uncapture of the IOL. And if we see that situation, I don't think conservative treatment, just give him dilating drops and so on, will help to correct the position of the IOL. So I may go and try to inject Helon through those the phaco corneal incision which he had before. If I can go through it, and I try just to inject Helon and try to move that tilted IOL back in position and reform the AC with Helon. And maybe that can help him at this stage.
Well, without changing the underlying pathology, if there is an underlying pathology for this tilted IOL and captured IOL, they probably will not change anything, Prof. Osama. But anyhow, he is now in the early post-op period. Probably I will be more conservative in this very delicate gentleman.
Professor Saleh?
Yes.
Can we just move on till the end of the case for the sake of time?
No problem.
Sorry, thanks.
Okay, so the question was overfiltration. We didn't go for further investigations like UBM or B-scan, but we tried more conservative management in the clinic. We applied a pressure patch over the blib and reassessed the patient at the end of the day with no improvement. So as you know, he's a one-eyed patient, so we decided to admit him and book him for AC reformation with viscoelastic and IOL repositioning at the same time under topical anesthesia. We kept him on Predfort and Oflox and added atropine as well. And followed him next day with where we saw the AC was actually shallower. It was grade 2 with iridocorneal touch up to the pupil. So we withheld the prednisolone acetate, the topical steroids, and re-evaluated him after 2 days with no improvement. So we booked him for blib revision under local anesthesia, where the conjunctiva was opened again and the flap was reassessed. We actually found a gap, so additional sutures were added to the flap, and then we closed the conjunctiva again and put him on atropine and Predfort and Oflox. The next day, the AC was moderate in depth. The bleb was formed, but with micro leak. So we applied 22 millimeters diameter bandage contact lens and kept him on Predfort and Oflox. And he was stable the next day. So we discharged him and gave him follow-up after a week, where he presented with vision, counting fingers, unrecordable IOP, and very low blib with no leak. Of course, after removing the bandage contact lens. And the AC was even shallower. It was flat with grade 3 with lenticular, IOL corneal touch. The retina was hazy, but apparently flat. So at that time, we were thinking of either ciliocoroidal effusion or cyclodialysis cleft. So we we ordered B-scan and UBM. As you can see, the UBM showed the peripheral supraciliary fluid collection, as you can see it in both photos. And the AC was flat with edematous cornea and corneal folds, while the B-scan showed a flat posterior pole with no choroidals, only shallow peripheral anterior choroidal detachment. So I'd like to open the discussion again for the last time for the treatment at this stage.
Did you have in mind that he has malignant glaucoma and the pressure couldn't be checked or couldn't be recorded because the cornea and the iris is touching? Did you have that in mind?
We had it in mind, but after this UBM, our impression was annular ciliocoroidal effusion because we saw the fluid 360 degrees in the supraciliary space.
So I think at this stage we have to go in and reform the AC and also to suture the wound, the scleral flap, to decrease aqueous drainage there. That may help to push everything back, because if we leave it like that, most probably the cornea will become decompensated and and become scarred, and he will lose vision from that, and plus he will develop peripheral anterior synechial. So at this stage, I will just go in and I will inject Helon in the AC and retry to revise the trap, and I may go in the varus plana and go and withdraw some of the vitreous, and most probably in those age group it is liquefied, and that may help also to move back the iris lens diaphragm, plus injecting in Helon in the anterior chamber and resuturing the scleral flap. What do you think, Saleh?
Well, from the picture, first of all, Dr. Hanan, I would like just to elaborate on something that you said, a flat chamber. Flat chamber, of course, what we mean by flat chamber, should be an international language for those following us from the resident. A flat chamber where there is an endothelial touch, per se. Endothelial touch. Otherwise, even if there is total iridocorneal touch, still we cannot call it a flat chamber. Otherwise, we'll miss a proper communication between us. So flat chamber is a lenticulo-endothelial touch. This is first point. The second point, this is clear that he has, as you mentioned, celluloid detachment or accumulation of supraciliary fluids. The management here is medical first, atropine, nothing less than atropine, heavy steroid, probably topical steroids, and of course you continue antibiotics. I wouldn't touch the eye as long, and I'll pay attention to the cornea. If it is touched by the IOL or so, then probably I'll give him 2 or 3 days, then I'll intervene, as Dr. Prof. Sama said. But my intervention here is to go and drain supraciliary fluid, and I wouldn't touch the vitreous. I will just go and about the dimensions of how to drain the supraciliary fluid, which is very safe, extraocular, and that's all. But first, I will try medical treatment, atropine, Brett 40, antibiotic for 2 or 3 days. If the cornea is away or not threatened, I can wait even more than that. Yes.
Thank you, Prof. Actually, we started him on medical treatment first and observed him after a week. We gave him frequent steroids, Bradford Q 2 hourly, and atropine TID, and gave him 7 days follow-up, where he presented with dramatic improvement of vision, IOP, and AC depth. The UVM was repeated with much improvement of the supraciliary fluid. So we started tapering the steroid then, and gave him 1 month follow-up, where you can see the vision was stable, 2400 and IOP 11. The bleb was shallow or almost flat, but and a bit congested. But the AC was deep and quiet with stable IOL in place and flat posterior torque. So that was the last visit. Unfortunately, he couldn't follow up after that because of the current condition of coronavirus. That's my case, and thank you, Prof. Saleh. Thank you, Prof. Osama.
Thank you very much. Nice presentation.
As usual, it's an outstanding presentation. It's very, teaching condition case really, and I hope those following us, they learn something from this beautiful case. Thank you.
Thank you, Dr. Hanan, for this excellent presentation. We just have some questions from the participants. The first question is about the retina status pre-op. You didn't mention if the patient was followed up by retina or not, or the retina, is it stable or not stable? If he has edema, is he receiving any anti-VEGF?
Yeah, I actually mentioned it at the beginning. Yeah, pre-op in the first slide, where I said that he was following in retina, received multiple anti-VEGF injections, PRP for severe NPDR, and he's continuing follow-up in retina. Actually, he has stable retina after PRP and injections with signs of severe NPDR on the right eye, and he has history of CRVO on the left, which is also stable.
Okay, good. I just have, for me, I have one comment here, not related to your case. In general, in NVGs, there is always a miscommunication between glaucoma and retina. Let's say we have fresh NVG case. First, they should receive laser and anti-VEGF, then refer to glaucoma. Here, we have a gap always. Sometimes we just give them drops, and he's stable for a couple of days, then not followed up by retina, then return to glaucoma with high IOP with NVIs again. So always make sure that the patient is following up with retina as well as with the glaucoma, not only with glaucoma. This scenario, I've seen it many times, that the patient is only with glaucoma but not with retina, and we just return to square one again. Other question is, can we just do phaco? And one of the participants is asking about phaco plus micropulse CPC. Is it a good option here?
What about Dr. Sama? My answer, if Dr. Marco Sama allowed me.
Yeah, go ahead.
Yeah, honestly, I'm not, definitely this is my school, the school that I believe in it. I wouldn't touch the ciliary body or any psychodestructive procedure for this patient or any patient before I try, although there are a lot of reports talking about the micropulse or endocyclic photocoagulation or so, I wouldn't touch the ciliary body at all unless I exhausted all the traditional and well-known and predicted procedure. For example, the hysterectomy, trabeculectomy, or so, or even repeat them before I touch the ciliary body. It's very dangerous, in my opinion, despite of a lot of reports that are talking about ciliary psychodestructive procedure, whether by CBC or endolaser or whatever. I'm against this. This is my opinion. I wouldn't touch it. I will go for phaco alone with medication, or I'll do the same thing as Dr. Hanan approach. She did already. Yeah.
I think this.
Yes.
If
Go
I may
ahead.
say, micropulse here may have a role, but usually those patients with progressive diabetic retinopathy and all these problems and so on, they have glaucoma for a long time. The ciliary body is so fragile, and if you do CBC for them, most of the time they end into ptysis bulbi. They shut down. So that's the question. Always we have to keep in mind that we may go and push that patient into ptysis bulbi by doing the CBC or cyclophotocoagulation. So keep that in mind when you want to do that.
We have some questions. First, I would like to say hi to Dr. Samir.
The MVG,
yes.
Abdurrahman, MVG,
yes.
You mentioned something about MVG. I don't know what's محل بالعرب, لكن you talked about MVG. The MVG, I have special interest in it. MVG, yes, as you mentioned, should be controlled, the MVI, whether by multiple injection or so, before the glaucoma touch the patient. Whatever you're going to do for to control the pressure from surgical point of view, interventions, I mean, whether CBC, trabeculectomy, whatever you choose, whatever, it will not work as long the underlying pathology is not under control. This is for residents. You have to control the underlying pathology, otherwise you're wasting your time and the patient time. Yeah. Okay, go ahead.
Yeah, we have one question about systemic steroids. Is it a good option in here, systemic steroids?
In this case, huh?
In this case, yes.
Yeah, Prof. Sama, this is your turn.
I don't think so. Usually the topical drops is enough for those patients. I never use systemic steroid. I always just give them topical steroid plus atropine and so on.
I agree with Sam. There is a lot of controversy regarding systemic steroid. We are not sure, are they helpful or not? But I don't think there is a harm. If there is no contraindication for it, I don't see any harm of that. There is a lot of controversy when you look to the literature. But my way, as Prof. Sama said, I will go for topical atropine and metformin. But in case somebody used it, I don't see anything that you can say or you can blame him or so. Yeah.
Dr. Samir Ahmed is a former glaucoma consultant at KKH. He has a comment. He's saying that he's not with phaco plus major glaucoma surgery in this situation. But you can do phaco plus micro, like goniotomy or something, not major glaucoma surgery like trabeculectomy.
Is he online?
What's that?
Is he online with us?
Yeah, he uses you. Phaco only.
Okay, my dear Samir, we missed you so much, by the way, and still, yes, I respect your opinion, but at least in my school and the way I'm teaching my fellows and resident, I will not touch the cellular body unless whether with laser or with the stent or whatever that you are using with the new modality of anti-glaucoma procedure. I will just go either with phaco alone and use medication later on if I need it, or to go with the conventional way, trabeculectomy in this patient. And as I mentioned, take a precautions that I have to close the flap very well and not to have any oozing of aqueous under the flap in the early post-op days. And then I can titrate the pressure with time depending on the pressure level by massage or by socializing. Thank you.
Thank you, Prof. Saleh.
Thank you.
And thank you, Dr. Hanan, for this excellent presentation. Our next presenter is Dr. Dania Bamifleh. Dr. Dania is a glaucoma fellow at King Khalid Eye Specialist Hospital in Riyadh, Saudi Arabia. Dr. Dania, you can go ahead.
Okay. Assalamu alaikum. Marhaba.
Salam.
Can you see my presentation?
Yes.
Yes.
Yes, it's
okay. Great.
Yeah, I will give you some comment, not now, but later on from the title. Anyhow, go ahead.
Assalamu alaikum. Marhaba. كلكم جميعا. I'm really happy to be here and presenting with the Saudi Glaucoma Group, and welcome to our guests also from the Saudi Ophthalmology Society. My case is going to be about this forgotten entity. It's a phacolytic glaucoma case. Okay. I have no financial interest in the presented material. The key points in my presentation, I'm going to have the case presented first. After that, we'll talk about a bit about the background of the phacolytic glaucoma in general and what looks like a phacolytic glaucoma but isn't, and the prognosis for such a case, and then summary. So our case was presented to KCASH, and I have to acknowledge Dr. Conrad Chargo and my colleague, Dr. Abdullah bin Hamid, for helping me managing this case and recruiting the investigations and the photos and taking care of the patient. So our case actually presented during this time of the COVID-19, so it must be something serious. And he actually came during the lockdown, the 24 hours curfew. He's a 55-year-old gentleman. He presented to ER complaining of pain associated with headaches for 2 days in an eye that was poorly seeing. So upon tackling more on the past ocular history, it turns out to be the patient was actually poor in this eye vision for more than 7 years, and the pain only started for a couple of days associated with the headaches and nausea. He denies any history of trauma that was recent or remote. Fellow eye, he underwent cataract surgery uneventfully 7 years ago, and everything was fine. He denies any history of previous glaucoma or family history of the disease. Upon examination, the right eye was within normal limits with a pressure of 10, with a good vision at 20/30, quite pseudophakic, with a normal healthy disc and flat retina. The left eye is the eye of the concern. The visual acuity was only hand movement with a pressure of 50. Apart from that, the anterior segment exam showed a cornea that's mildly edematous with a few deposits on the back surface of the cornea. And there seems to be a very thick fibrinous reaction filling the anterior chamber. Apart from that, there was deep anterior chamber. A few cells were here and there, but the main issue was actually the flare. Apart from that, the patient was dilated and seems to be 2 clock hours of posterior synechia with a white hypermature cataract. Right eye was unremarkable. This is a picture of the left eye. As you can see, the mild corneal edema, but mainly there seems to be a fibrinous reaction in the anterior chamber. This is a reflection of the eyelid, so this doesn't concern us. These are the deposits on the back surface of the cornea, and you can see the hyperly mature cataract underneath. You can see the fibrinous reaction, very thick. Okay, so we did a B scan to rule out any posterior pathology, and seems to be everything within normal, clear vitreous, flat retina, no evidence of any tumors. with actually an elevated optic nerve rather than cupped. But everything seems posterior-wise fine. So we did an ultrasound biomicroscopy to study more the anterior segment structures, and it turns out to be a deep, very deep anterior chamber, as you can see here. And there seems to be a bit of wrinkling on the anterior capsular surface, and the lens very hard, as you can see, with a surrounding liquefied material. And we were lucky enough to catch these small granules, which are representative of the lens material. So in summary, we have an open angle, hypermature cataract, a heavily fibrinous reaction filling the entire anterior chamber with unremarkable posterior segment exam. So we concluded that this is a case of phacolytic glaucoma. So my first question to the panelists, what would be the right surgical approach? Is it cataract surgery or cataract extraction alone? Or is it a mixture of cataract extraction with some sort of mix or filtering procedure, or only considering glaucoma procedure in this state?
Okay, thank you, Danny, for a nice presentation. For this patient, we see those cases, and I don't think that those cases will disappear soon in Saudi Arabia. It take longer time because we have a lot of those cases coming to the hospital. This patient, he has loss of vision or decrease of vision for long time, and then the pain and complaint just started 2 days before he come to the hospital. So most probably that he didn't have glaucoma for a long time, and only he had the cataract which become hyper mature and start causing the phacolytic glaucoma in the last 2 or 3 days. So those cases, I think we don't have to do filtration or mix or anything. We just do for them cataract extraction plus minus IOL. But I think nowadays you can put an IOL for them. And I have a lot of those cases, and they do fine. Just take the cataract out and put a lens alone. You don't have to do any glaucoma procedure.
Very nice. Thank you, Prof.
Okay. First of all, very nice presentation, Dr. Dania. Excellent. But I would like to, your exam, first of all, the title, as I told you. Title, nowadays, nobody using phacolytic glaucoma. Now we know what the underlying pathology. The proper term is lens protein glaucoma, where the high molecular weight lens protein is the injuring or the cause of the glaucoma. The reaction, the macrophagic or swallow macrophagic probably can add, but are not has been shown by experimental and other studies has no much role in that. Anyhow, this is the first thing. So when you say lens protein glaucoma, it is an international language. I know what you are talking about. So this is number one. Number two, in your examination, as long this is for teaching and so on, I wish that you included, which will help you a lot in taking a decision about afferent view defect. Here, you cannot do it, probably, I mean, direct one, but you can do a reverse afferent view defect. So it will tell you a lot about the status of the optic nerve head in general, whether in this case or any other case. So afferent view defect is extremely important. The other thing, you mentioned fibrous reaction. It is not a fibrous reaction. More, this is a protein. It is a protein. Yes, there is an inflammatory component in that, but the majority is a protein. The other thing is that you said a lens material that you saw in the UBM or so. This is calcium oxalate, usually present with these cases. This is a typical case. This is the way the lens protein glaucoma presents with. Usually, yes, although the age is 55, but still it can happen. Usually the other eye is either aphakic or pseudophakic. So the patient, as Professor Sama mentioned, they neglect the other eye. As long as they are managing with the good eye, they forgotten about this eye. Yes, the management here is, as Professor Sama mentioned, you don't need to go to anything else rather than cataract extraction alone. You don't need any further intervention, whether MIGS or filtering surgery or whatever. You don't need the glaucoma surgery at all in these cases. Cataract extraction alone with IOL, this is the patient will do very well, and you will find his disc later on completely healthy as Prof. Sama mentioned. Yes.
Yeah, thank you, Prof. So this is exactly what we did. It was cataract extraction. So the second question, it was to go for phaco or an ECCE. We actually went for ECCE. We felt it was safer and better to approach than the phaco in such a case. So a little bit background on the
just 1 minute, Daniel.
Yeah,
why you decide to go for extra cap rather than phacoemulsification? Why it is safer than phaco?
Yeah, we actually we attempted to do phaco, but we couldn't because of visualization issue, and also it was a problem with the rhexis. It turns out to be a large rhexis a bit, so we decided to go with the ECC instead of the phaco.
So you decide at the beginning phaco, and then you change while you are doing the surgery.
Yeah,
Thank
exactly.
The question, Prof, is very, 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 very important to Prof. Osama. I think, yes, we don't need to go for, I'm a phaco man, I can do phaco in any case. No, I think what you have done, and Prof. Osama suggested or recommended, is to go for ECCE. It is more controllable and less possible complication than go and do phaco. Agree with you, Prof. Osama, agree with you, Dr. Dayan. Yeah.
Okay, so the background, it's a secondary type of open-angle glaucoma that occurs mainly in developing countries due to the presence of the hypermature cataract, but it can also be due to non-penetrating or blunt trauma. The pathophysiology, the presence of microscopic leakage of the high molecular weight, as Prof. Saleh was mentioning, proteins with an intact anterior capsule causing a severe inflammatory reaction and characterized by the presence of cells, flare, and white particles in the deep anterior chamber. Gonio would be widely open, and the corneal edema could be plus or minus, but occasionally these people can have hypopion. This is a different patient, not our patient, but some people can have hypopion as well. So the pathophysiology, the acute rise of IOP is actually caused by the blockage of trabecular meshwork caused by the protein-laden macrophages and the inflammatory debris. And both the trabecular blockage and the high IOP are actually reversible when lens cataract extraction is once done, and the steroids reducing the inflammation. On the other hand, if a late presentation was there, cataract extraction will not be enough or not be sufficient for the control of IOP, and there may be permanent damage to the trabecular meshwork. In these cases, actually, it's recommended to perform cataract extraction with combined filtering procedure. This is a very nice study done by Dr. David Epstein. It's very nice. It gives you like an overview of all types of lens-induced glaucoma and their pathophysiologies. I'll emphasize only on the parts of that are concerned of the phacolytic glaucoma. The presence of high molecular weight protein, it's a more specific test, and they have actually done this on 12 patients that were diagnosed as a phacolytic glaucoma. They took a sample of the aqueous humor, and they found that it was more specific testing than the presence of macrophages, as macrophages can actually be decreased with the use of topical steroids. And because this taking or paracentesis sample is not applicable, they made more illustration or more description of the examination regarding the clinical evaluation. So they emphasize that the presence of white patches on the anterior lens capsule, which are representative of the macrophages that are attempting to seal the capsular leaks, the presence of white chunks, presumed lens origins that are freely floating in the anterior chamber, and third of all, the presence of a heavy flare but mild cellular reaction in the anterior chamber is also a suggestive option. So yeah, we've already done that. This is also a nice article. It's when to go for cataract surgery alone or when to go with a cataract surgery combined with a glaucoma procedure. I like this study. It has recruited 135 cases of phacolytic glaucoma, and they further divide them into hold on. They further divide them into cataract surgery alone versus cataract surgery with a trap, and turns out to be that they chose the cases for cataract plus trap in patients that were symptomatic more than 7 days, or people that have uncontrolled IOP despite maximum medical therapy. Sorry, there's some problem. Okay, so in the early post-operative period, the IOP was significantly lower in the combined cataract and glaucoma procedure compared to the cataract surgery group alone. But at 6-month interval, there seems to be no difference in IOP or the visual acuity between the two groups. It's reasonable to conclude that eyes with a long duration of phacolytic glaucoma, additional surgery of trabeculectomy to the cataract surgery is safe and prevents the post-operative rise of intraocular pressure and decreases the need for systemic hypotensive medications. Sorry about that. It's a problem with the application. I'm sorry. Do you see it?
Yeah, we can see the slide.
Yeah, but you cannot see the memo that it says. It's just one memo. It keeps hanging. Okay. Stop sharing and then. It's okay. I'll try to stop sharing, but it keeps hanging. Okay. Seems to be a problem.
While you are fixing your slide, if I may just mention one point, if the patient had long-term or had high pressure for a long time and he had the pain for 2-3 months and so on, I think from the beginning you don't do just cataract, you just go ahead and do combined cataract and trabeculectomy. This is, I find it very useful if you are in doubt and the patient has uncontrolled pressure for a long time. You expect that from the history, because most of those patients, they come from rural area and they find difficulty to come to the hospital immediately. So most of the time they have this pressure and pain and so on for 2, 3, 4, 6 months before they come. So if I expect from what the patient is mentioning that he had glaucoma for a long time, I want to just do cataract and then wait and do that, because in the, most probably if I do the cataract and then after some time the pressure is not controlled and I tell the patient to go ahead and have another surgery, most probably he would say this doctor doesn't know anything and he will go away. So it's better to do combined from the beginning.
So for the sake of time, can we just have some questions till Dr. Dania?
Yeah.
Before you, Abdurrahman,
Yes?
can I comment before the question?
Yeah, sure. Yeah. Go ahead.
First of all, it is very nice presentation, as I said. The mechanism, Dr. Dani and my colleagues and those who are watching us, the mechanism is, I would say, almost purely due to heavyweight molecular lens proteins. And this has been documented by experimental and other studies. The other thing, this is one of the acute congestive glaucoma. It's one of the types of acute congestive glaucoma. The patient wouldn't wait for 3 months or 4 months or 6 months. Usually the pain, they force them to come to the physician, whether within the same day or after 2 days, or after a week or 2 weeks, depends, as Dr. Prof. Osama mentioned, from rural areas or so. So they are an acute congestive glaucoma. So Regarding to do with full respect to the article that you mentioned, and I came across that article a long time ago from India, comparing the cataract extraction versus combined procedure. You don't need to do any glaucoma procedure in these cases. What do you need to do when you remove the cataract, whether by ECCE or phaco? You need to do a very good washout of the anterior chamber. Whatever in the angle, the macrophagic response later on, they will take care of it and they will engulf it and take it off of the angle. So I never, although I have a good experience with phacolytic or lens protein glaucomas many times, I never think about even combined procedure. The other point somebody mentioned, either in the article or so, they said anti-glaucoma medication. Usually anti-glaucoma medication wouldn't help in reducing the pressure. Probably the steroids, topical steroids is important, they quieten the eye a little bit, as Prof. mentioned. Anti-glaucoma medication may reduce the pressure a little bit, but they will never get the pressure controlled unless in small or little or intermittent types of lens protein glaucoma. Yes, please. Yes.
Yes, we have some questions. Dr. Talib is asking, he's saying or suggesting that he will do small incision cataract surgery, sutureless small incision cataract surgery rather than ECCE.
Yeah,
Do you agree?
I agree with any cataract extraction, whether small incision, phaco, ECCE, the procedure that you feel that you're confident to do, or you will be able to control the condition. So I don't mind about the types of way of cataract extraction. I have no.
Some of the participants are asking about steroids pre-op to just quieten the eye a little bit.
Okay.
Any other comments, Prof?
I think it is advisable to put them on cyclogel and also to give them the steroid to quieten the eye. And as Dr. Saleh mentioned, that sometimes it is very difficult to control the pressure, and pressure in spite of all medication is still high. For those patients, I usually give them mannitol 1 hour before surgery to decrease the pressure before I take them and do the extra carb or phaco emulsification surgery.
Thank you, Prof.
You're welcome.
Dr. Dania, are you around? Dr. Dani Bamfleh. I think we lost her, unfortunately.
I think she ran away to Jeddah.
She didn't hear us, and that's very important. Yeah, I would chat in.
Unfortunately, it was an excellent engagement. I think she lost the connection.
Hanan?
Yeah, she lost the connection, but she's trying to go in again.
Yes, I think she lost the connection. Anyway, for the meanwhile, I just want to remind you about the next Saudi Ophthalmological Society webinar session, which will be next Friday, 19th of June, at the same time, 9 p.m. The title will be Congenital Corneal Opacity. It will be presented by Dr. Ken Nishan. This will be next week, inshallah. For the meanwhile, I'm not sure if Dr. Dania will be back or not. We can just welcome Mr. Shadi Qandil, which is the representative of the sponsoring company, Mandi Pharma. You can just go ahead, Mr. Shadi. If you have a presentation, you can go ahead.
Assalamu alaikum. My name is Shadi Qandil. I'm head of medical department Mandi Pharma, responsible for Middle East, Turkey, and Africa. And of course, it will be my pleasure to present to you today some of my slides related to Saflotan, our first prostaglandin-free analog, which is present in the market. I'm not sure if my slides are there or not.
No, we don't see it.
Okay.
It's not there.
Okay, I'll just give me a second.
You have to share.
Shadi, yes, we are seeing the name. Shadi
Shadi Qandil.
Shadi Qandil.
Yeah, but we cannot see the slides.
No slide.
No.
Yeah, Dr. Shamran, if you can give him the availability to share, it will be good.
Actually, Dr. Shadi can share his screen. He's panelist now and he can change his screen.
Actually, I'm trying to share my screen, but there are some problems, I guess, in sharing it.
For the meanwhile, yes, you can go ahead.
Maybe Dr. Abdurrahman, if you have some question in the question and answer,
Yes.
you want to, then you can go ahead. Tell Dr. Shadi.
Yeah, I have a question for Prof. Saleh and Prof. Osama. One of the participants is asking about at what disc cupping level is okay for glaucoma surgery regarding the phacolytic. Is there any cut line or something?
Usually in phacolytic, usually we don't see the posterior ball. It's very difficult to see the optic nerve to assess it well. But I think those patients, they have to have cataract surgery to start with. Whether we have to do with a trabeculectomy or not, that comes next. But they have to have the cataract removed to assess the optic nerve. And most of the time, if they have it for a short time, the phacolytic glaucoma, usually they have a good optic nerve. So it's very difficult to see the optic nerve to assess it well.
Yes, it's difficult. Yeah, but hello?
Yeah.
Yes,
we can hear you.
We can hear you.
You are hearing me now?
Yes.
Yes.
The B-scan can give you an idea, but I wouldn't look for the B-scan. I wouldn't depend on the B-scan. I will depend, as I mentioned to Dr. Adania, with our, ABD, it is a very sensitive way of evaluation. It's very simple, basic exam, but we are always forgetting about it. It tells you about the status of the nerve that you couldn't see compared to the nerve in the other eye. So ABD, if there is no ABD, definitely whether direct or reverse, the disc is similar to the other eye. This is definite. This is even for the cataract or for opaque cornea or for vitreous hemorrhage or anything that can prevent visualization of the optic nerve head. Yes, ABD, you can depend on it and you can say, this is the status of the nerve. I can say it per se, no problem. Yes, you cannot. Of course, there are other basic examination like color vision and Maddox rod for the evaluation of the macula. But for the disc, ABD is the best thing. It is very sensitive to the optic nerve head. Yes.
Thank you, Prof. Saleh. Mr. Shadi, you can start your presentation. Mr. Shadi, are you around?
Is my screen now?
Yeah,
I'm here. Is my screen available?
Yes, we can see
the
it.
Screen?
Yes.
Okay, perfect. So in my presentation, I'll be talking about saflotan, the first preservative-free prostaglandin analog. Of course, nowadays, glaucoma therapy-related ocular surface disease is becoming one of the serious pathology, and it has broad spectrum of clinical manifestation that seriously affects the long-term glaucoma care. Preservatives, which are mainly benzalkonium chloride, which is present in most of anti-glaucoma drugs, is the main factor and the main cause that aggravate and cause ocular surface disease. With the recent updates, we found that the prevalence of ocular surface disease accounts for about 42% in glaucoma patients using medical treatment, and at least 1/3 of glaucoma patients are suffering from severe symptoms of ocular surface disease. That gives us a clear idea and importance about the proper diagnosis of ocular surface disease and considering it in management of glaucoma in order to achieve our better tolerability for the patient, improve patient adherence and patient compliance. Therefore, we reach the utmost goal, which is long-term successful treatment with medications. The preservative-free prostaglandin analogs is a new novel, not really new, but it's a novel technique in management of glaucoma, and one of the tools which have been introduced to the market in the past 15 years, in which we eliminated the preservatives and the toxic parts of the preservative, which is benzalkonium chloride, from the eye drops in order to remove its harmful impact on the ocular tissues. Saflotan, the tafloprost preservative-free, is considered the first prostaglandin analog which is preservative-free introduced into the market, and it was launched in 2008. In this study, simply we tried to show the improvement and the effect of changing the patient and switching the patient from preservative eye drop to preservative-free eye drop. As you can see here in the yellow bars, these are the signs and symptoms of ocular surface disease in patients receiving preserved eye drops. And then during the second visit, we shifted them into preservative-free eye drops, and you can see there is a statistically significant drop in the signs and symptoms of the ocular surface disease, thus improved a lot the tolerability and the patient adherence, as well as the patient quality of life. Saflotan is mainly indicated for reduction of elevated intraocular pressure in open-angle glaucoma or ocular hypertension as a monotherapy or in conjugation with beta blockers. Contraindication of Saflotan. Saflotan is contraindicated only if there is hypersensitivity to tafloprost or any of its excipients. The main key factors or key attributes of Saflotan, as we said, it is a preservative-free, so we eliminate the cumulative toxicity resulting from preservatives onto ocular tissues. Saflotan is a prodrug when it is administered to the eye, and it is also a potent and highly selective to FP receptor agonist. The diurnal IOP reduction. Yes.
Can you make your presentation full screen, please?
Okay, sure.
Yeah.
Is it better now?
Yeah, much better. Thank you.
Okay. Okay, you're welcome. Saflotan, as I mentioned, is a prodrug that is potent and highly selective FP receptor agonist. The diurnal IOP reduction after 42 days from using Saflotan is about 33% of the intraocular pressure. Here is a picture which shows that, as we mentioned, it is a prodrug. Saflotan, when it is administered to the eye, it is administered in the form of tafloprost isopropyl ester, and then it is converted by a esterase enzyme which is present in the aqueous humor and converted into tafloprost acid, which is the biologically active molecule that acts on the uveoscleral outflow, thus reducing the intraocular pressure. As some mentioned previously, that the preservatives are having some importance in increasing the corneal penetration power of any molecule. However, this applies mainly for hydrophilic molecules, while for tafloprost, it is a lipophilic molecule. So in this trial, we try to prove that adding preservative to the tafloprost molecule will not affect the intraocular pressure reduction power of tafloprost. So here we add two arms of patients, one arm receiving Saflotan, which is preservative-free tafloprost, and the other arm received tafloprost with preservative, and we measured the intraocular pressure over 4 weeks. As we can see, the two lines are identical, which proves that adding preservative to tafloprost will not affect its efficacy and its reduction power of the intraocular pressure, as it is a lipophilic molecule, as I mentioned, and doesn't have any effect on adding the preservative to it or not. One of the main trials and the major trials for Saflotan was this one, when comparing it to latanoprost in long-term patient. This study measured the efficacy of Saflotan versus latanoprost over 2 years in 402 patients. As we can see from the results, that both Saflotan and latanoprost reduced the intraocular pressure significantly in the patient along the 2 years, and this reduction was sustained over the 2 years, which proves that the efficacy is sustainable in both molecules. However, for Saflotan, it shows much more tolerability and less adverse events related to the ocular surface health for the patient compared to latanoprost. The 24 IOP control with Saflotan, as all of us know that glaucoma is a 24-hour disease, yet in order to evaluate the effectiveness of any topical medication for glaucoma, it's better and it's very important to measure its 24-hour efficacy. This study was published in the British Journal of Ophthalmology in 2013 by Professor Constas, where he assessed the efficacy, a 24-hour efficacy of Saflotan versus latanoprost in patients having ocular hypertension or primary open-angle glaucoma. This is a prospective observed mask crossover study. in which the baseline intraocular pressure for the patient was 24 till 33 millimeter mercury, and the intraocular pressure was measured 6 times per day with a fixed interval between 4 hours using either sitting position using Goldman or a supine position using Perkins tonometer, and the study duration was for 3 months. And as you can see from the results, that both drugs was successfully able to reduce the intraocular pressure over the 3 months period for the 24 hours. And here we can see that the mean intraocular pressure at the baseline was 24.9, while adding latanoprost to it was reduced to 17.7, and for saflotan, which is preservative-free tafloprost, 17.8. This study was the first study to assess the 24-hour efficacy, and it shows that both molecules, whether preserved and preserved-free, have the same efficacy, yet the tolerability and safety-wise was much more better in the arm of saflotan, the preservative-free medication. As we said also here, the percentage of reduction from the baseline for saflotan was 28.5 versus 29.3. However, the preference of lowering the intraocular pressure was in the daytime for latanoprost, while for the nighttime was for saflotan. Another important pivotal trial, which is assessing the 24-hour efficacy and ocular surface health with saflotan and conduct preservative-free in patients who are insufficiently controlled with the preserved latanoprost as a monotherapy and showing signs and symptoms of ocular surface disease. This study is a prospective crossover observer masked, which is also for 3 months, and it is open for several types of open-angle glaucoma, whether primary open-angle, pseudo-exfoliative glaucoma, or pigmentary glaucoma. And the patients who are enrolled in this study must show ocular surface disease signs and symptoms, having intraocular pressure more than 20 millimeter mercury, even they are using latanoprost as a monotherapy. The patients were evaluated over the 24-hour the intraocular pressure using Perkins and Goldman the same way with the fixed time interval every 4 hours check for the intraocular pressure. And as we can see here, the two arms of saflotan and latanoprost also is showing that both of them are really identical in the lowering effect of the intraocular pressure and controlling the 24-hour of the intraocular pressure. But however, we can see here that the adverse events was significantly lower in the arm of saflotan compared to latanoprost, with 34 adverse event in the arm of saflotan versus 56 in latanoprost, which is statistically significant and show better tolerability. This study shows that statistically superior 24-hour efficacy with saflotan versus preserved latanoprost in glaucoma patients with signs and symptoms of ocular surface disease. This efficacy superiority may be attributed to the concomitant improvement in ocular surface health and tolerability. Also, this study identified an efficacy and tolerability advantage when we switch to preservative-free option from preserved latanoprost in the patient who have suffering from primary open-angle glaucoma or open-angle glaucoma in general and exhibit ocular surface disease signs and symptoms. The summary of saflotan, it is developed to eliminate the preservative toxicity. Saflotan provides powerful and uniform 24-hour IOP reduction, day and night medication. As essential therapy or when switching from other prostaglandin, it significantly reduced symptoms and signs of ocular surface disease and thus enhanced patient tolerability and compliance and improve quality of life on the patient and successfully helps to maintain patient on medication for longer time and improves the outcome of medical treatment of glaucoma. Thank you for your time, and I'm willing to receive any question.
Is it available in market now?
Yes, it's every market now, yeah.
Very good.
Saleh, any comments?
Nothing. You know
Thank you, Mr. Khalid. Excellent presentation. Yes.
Thank you so much. Thank you so much. It was an honor presenting to such great panel, and I'm really happy to present in front of you.
Thank you, Shadi.
Thank you. Thank you, Professor Saleh and Professor Osama. Thanks.
Thank you very much, Abdurrahman. Thank you very much. Nice
and
presentation.
Thank you for Dr. Hanan for her excellent presentation, and as well for Dr. Dani.
Dr. Dani.
We love her, but she did very well.
Thank you.
And I would like to thank all
everyone, and she's thanking you.